Type 2 diabetes mellitus continues to rise worldwide. It strikes Indians a decade earlier than the rest of the world. More than half of patients with type 2 diabetes do not achieve blood glucose targets, despite the availability of a wide range of effective glucose-lowering therapies. Non-adherence to the treatment, poor patient education, and long-term cost of therapy are leading causes of poor glycemic control. The failure to maintain good glycemic control increases the risk of diabetes-related complications, which leads to excessive long-term healthcare costs. This calls for a revolution in diabetes management. Join hands to ignite the revolution in T2DM management. Introducing Ignalis M, the revolutionary OAD. Ignalis M is the combination of sitagliptin and extended-release metformin. Ignalis M addresses non-adherence and cost of therapy as it is available in revolutionary formulation at a revolutionary price. The extended-release metformin in Ignalis M makes it truly once daily. Ignalis M has proven bioequivalence to Innovator with multiple dose range studies. In T2DM, initiate early Ignalis M, the revolutionary OAD, as it targets 7 out of 8 ominous octet. Ignalis M is available in a comprehensive range with revolutionary pricing. Join us to ignite the revolution in T2DM management with Ignalis M and Ignalis through expanding the blue ring, which addresses early diabetes detection, patient education, better diabetes monitoring, and accessibility. Revolutionize T2DM management with Ignalis M, the revolutionary OAD. Type 2 diabetes mellitus continues to rise worldwide. It strikes Indians a decade earlier than the rest of the world. More than half of patients with type 2 diabetes do not achieve blood glucose targets, despite the availability of a wide range of effective glucose-lowering therapies. Non-adherence to the treatment, poor patient education, and long-term cost of therapy are leading causes of poor glycemic control. The failure to maintain good glycemic control increases the risk of diabetes-related complications, which leads to excessive long-term healthcare costs. This calls for a revolution in diabetes management. Join hands to ignite the revolution in T2DM management. Introducing Ignalis M, the revolutionary OAD. Ignalis M is the combination of sitagliptin and extended-release metformin. Ignalis M addresses non-adherence and cost of therapy as it is available in revolutionary formulation at a revolutionary price. The extended-release metformin in Ignalis M makes it truly once daily. Ignalis M has proven bioequivalence to Innovator with multiple dose range studies. In T2DM, initiate early Ignalis M, the revolutionary OAD, as it targets 7 out of 8 ominous octet. Ignalis M is available in a comprehensive range with revolutionary pricing. Join us to ignite the revolution in T2DM management with Ignalis M and Ignalis through expanding the blue ring, which addresses early diabetes detection, patient education, better diabetes monitoring, and accessibility. Revolutionize T2DM management with Ignalis M, the revolutionary OAD. Type 2 diabetes mellitus continues to rise worldwide. It strikes Indians a decade earlier than the rest of the world. More than half of patients with type 2 diabetes do not achieve blood glucose targets despite the availability of a wide range of effective glucose-lowering therapies. Non-adherence to the treatment, poor patient education, and long-term cost of therapy are leading causes of poor glycemic control. The failure to maintain good glycemic control increases the risk of diabetes-related complications, which leads to excessive long-term healthcare costs. This calls for a revolution in diabetes management. Join hands to ignite the revolution in T2DM management. Introducing Ignalis M, the revolutionary OAD. Ignalis M is the combination of sitagliptin and extended-release metformin. Ignalis M addresses non-adherence and cost of therapy as it is available in revolutionary formulation at a revolutionary price. The extended-release metformin in Ignalis M makes it truly once daily. Ignalis M has proven bioequivalence to Innovator with multiple dose range studies. In T2DM, initiate early Ignalis M, the revolutionary OAD, as it targets 7 out of 8 ominous octet. Ignalis M is available in a comprehensive range with revolutionary pricing. Join us to ignite the revolution in T2DM management with Ignalis M and Ignalis through expanding the blue ring, which addresses early diabetes detection, patient education, better diabetes monitoring, and accessibility. Revolutionize T2DM management with Ignalis M, the revolutionary OAD. Type 2 diabetes mellitus continues to rise worldwide. It strikes Indians a decade earlier than the rest of the world. More than half of patients with type 2 diabetes do not achieve blood glucose targets despite the availability of a wide range of effective glucose-lowering therapies. Non-adherence to the treatment, poor patient education, and long-term cost of therapy are leading causes of poor glycemic control. The failure to maintain good glycemic control increases the risk of diabetes-related complications, which leads to excessive long-term healthcare costs. This calls for a revolution in diabetes management. Join hands to ignite the revolution in T2DM management. Introducing Ignalis M, the revolutionary OAD. Ignalis M is the combination of sitagliptin and extended-release metformin. Ignalis M addresses non-adherence and cost of therapy as it is available in revolutionary formulation at a revolutionary price. The extended-release metformin in Ignalis M makes it truly once daily. Ignalis M has proven bioequivalence to Innovator with multiple dose range studies. In T2DM, initiate early Ignalis M, the revolutionary OAD, as it targets 7 out of 8 ominous octet. Ignalis M is available in a comprehensive range with revolutionary pricing. Join us to ignite the revolution in T2DM management with Ignalis M and Ignalis through expanding the blue ring, which addresses early diabetes detection, patient education, better diabetes monitoring, and accessibility. Revolutionize D2DM management with Ignalis M, the revolutionary OAD.
Good evening, everyone. On behalf of Intas Pharmaceutical Limited and Janit Division, I, Dr. Mercedes Nak, welcome you all to this Endocrine Talk Show, episode 5. This Endocrine Talk Show is a monthly webinar series in which we try to dissect some of the commonly encountered but not discussed commonly topics so that we can have better understanding about the various aspects in the endocrinology. So today we have one of the unique topic that is about genitourinary system in diabetes. And to guide us today, to moderate today's session, we are having with us our co-director for this program, Dr. Supankar Chaudhary sir. He's a professor and head at Department of Endocrinology at SSKM Hospital, Kolkata. He is also a former editor-in-chief for Indian Journal of Endocrinology and Metabolism. He held various positions in multiple medical professional bodies, including the Endocrine Society of India, RSSDI, as a president as well as secretary. He is also a member for subject expert committee for CDSC of Government of India and has many publications to his credit. So with this word, I hand over the digital podium to Dr. Subhankar Chaudhary sir and request him to introduce our panelists for the today's program. Over to you, sir.
Thank you very much. Very good evening. And we are really overwhelmed with the response that we have seen from our physician community over the last several months, starting from, let's say, the dark days of COVID lockdown. Uh, and that's, of course, because we are fortunate each time to be graced by wonderful panelists from different corners of our country. Like other evenings, this evening also, we have three eminent people. Uh, we were supposed to have four, but one, Dr. Shailesh Lodha from Jaipur, had to cry out at the last moment because of health issues in the family. His sister underwent a bypass surgery only possibly yesterday. But we still have enough firepower amongst our panelists. So let's go through them. So we have Dr. Pramod Gandhi, who is director and consultant endocrinologist at Kingsway Hospital in Nagpur. And he has several accolades to his name. He has been a regular faculty in national and international conferences in endocrinology. And we particularly fondly remember the wonderful SECon, the National Conference of Endocrine Society of India, that he hosted. He and his team, of course, hosted in Nagpur in 2019. So welcome, Pramod, to this show. Then we have with us a surgeon, a urologist. Okay, we have Dr. Rajiv Kovil. So we have an endocrinologist. Now we have a diabetologist. Once again, from Maharashtra, of course. This is Dr. Rajiv Kovil, who is medical director and consultant diabetologist at Kovil's Diabetes Care Center. And he's a consultant at different big named hospitals in Bombay, including the Nanavati Super Speciality Hospital. And he is also a regular speaker in national and international fora, and has been a teacher for postgraduate students of diploma in diabetes and has been a principal investigator. And as I was mentioned, can we go on to the third panelist of the day? So we're very happy to have with us a urologist, Dr. Shailesh Chandra Sahai, who is Associate Director in Urology, Uro-Oncology, and Robotic Surgery at Max Super Speciality Hospital at Patparganj in New Delhi. And he is an excellent surgeon, has a tremendous amount of experience in various urologic laparoscopic surgeries, including laparoscopic radical prostatectomy and laparoscopic nephrectomy, and has again won different accolades. So, welcome, Dr. Shailesh Sahai, to this show. Now, we take different topics, of course, and this time we would talk about the genitourinary system. When we talk about diabetes, we immediately talk about hypertension, dyslipidemia. We talk about the heart, the kidney, the nerves, so on and so forth. But somehow the genitourinary system probably does not receive its due recognition. So we are trying to make this up to our wonderful panel this evening. So one of the issues in relation to the genitourinary system we do understand is infections. Urinary tract infections are definitely a major problem in people with diabetes. In patients with diabetes compared to those without diabetes, there are specific types of affection, of infections that we see. So, can we ask our surgical colleague, Dr. Shailesh Sahai? When we talk of urinary tract infection in someone with diabetes, in what way is this different? Are there different microorganisms that are involved, or what is it?
See, in normal clinical practice, when we encounter a patient of UTI, then the history examination that makes a more important thing. And the first thing we ask the patient, do you have blood sugar raised and do you have history of diabetes? Because we know that if the patient is with UTI, especially having diabetic, then maybe my treatment approach is going to be a little different. So what difference which we notice in our clinical practice is number one is those patients with diabetes, they are actually very high prone for UTI. So they do have a history of recurrence of UTI. So like you have treated one episode of UTI and 1 week treatment normally suffice and culture becomes negative. But in those patients, you have to make sure that there is no recurrence. So might be they will need some prevention. Might be we need to see if there is some predisposing factor apart from this diabetes that is leading to this UTI. The culture pattern, as you asked, what we have seen and even the literature says, the most common organism in diabetic patient for UTI are E. coli and Klebsiella. So it's a basically
So,
gram-negative bacteria.
which is about the same in non-diabetic. So,
So yeah,
microorganism
it's the
choice is
same. If you see the normal population, the most common cause of UTI is gram-negative Enterobacteriaceae, which is E. coli and Klebsiella. So nothing different from them. But if you see the sensitivity pattern, then as per the literature, say the common antibiotics like third generation cephalosporin, or for that reason, this trimethoprim sulfamethoxazole, which was used to be very common treatment option in initial days. So now you find more of the culture reports to be resistant with these antibiotics. So the reason, although the literature says that there have been some instances in which it's found that trimethoprim does not act well in diabetic, but actually if you go in the details, then you find maybe the reason is due to recurrent hospitalization or recurrent UTI. Then patient have this exposure and then later on becomes resistant. So initially the pattern is same, but later on the normal antibiotics do not act well. So although you need to give the antibiotic judiciously on the basis of the culture pattern, but if the patient is having acute symptoms, then I would prefer going for little higher antibiotics, like the third generation cephalosporin do not act. So if patient is having fever, you are admitting, then go for the fourth generation cephalosporin like ceftriaxone, or see the TLC. So is sometime we have to give empirical antibiotic till the culture reports are available. So based on the clinical scenario, either we go for fourth generation cephalosporins, or sometimes even carbapenems may be required, but we have to be very judicious in giving this to prevent any further resistance. So these are the common pattern we see. And especially
right.
those patients who are not diagnosed with diabetic and patient comes with UTI, then first important thing I would like to convey everybody, don't forget to examine clinically the in male patient, the penis and the glands, because I have seen very commonly that those patients may not be having a history of diabetes. Once you see the glands and prepuce, they are badly infected, which points towards there is possibility of having a diabetes. So screen those patients and you'll find them that they are diabetic. So I've seen many such patients.
Right, and this is one area possibly we physicians do not commonly sort of would undress and look at the penis and prepuce, which the urologist possibly would do on a regular basis. So the other part, of course, is that in the context of diabetes, there are some sort of typical urinary infections, so-called emphysematous pyelonephritis or emphysematous cystitis. Those are almost exclusively seen in diabetes, though the microorganisms are not much different. So, Dr. Rajiv, Dr. Sahai just now said that he feels that those with diabetes tend to have recurrences of UTIs. So, what would be the underlying background for this? Would it be just the susceptibility to infection, or is it something to do with the urinary system that makes them more susceptible?
So you spoke about UTI, no, or GTI, sir?
No, UTI.
UTI.
Let's talk of bacterial infections.
Postmenopausal women obviously are at very high risk for urinary tract infection, both diabetic and non-diabetic. Men, I believe that unless their HbA1c and control is very poor, their chances are not very high. For a male, the genitourinary system is very complex, and I think that unless you have some form of obstruction, getting a UTI in a male is not so common. But very high hyperglycemia and HbA1c for very long, beyond 9%, would obviously precipitate a UTI. Having said that, asymptomatic bacteriuria is pretty common in postmenopausal women. And also asymptomatic pyuria is also pretty common in postmenopausal women. Whether we need to treat it, whether, that will depend upon a lot of clinical scenarios, cultures, their susceptibility, their recurrence. So all these things we need to take into consideration before we treat, because there'll be a lot of people with asymptomatic pyuria and bacteriuria, and whether we need to treat all of them is a problem. But elderly diabetics who are probably at home, bedridden, these are the higher risks for urinary tract infection, and probably we need to treat all these people. Otherwise, there'll be a lot of asymptomatic pyuria and bacteriuria which we may not need. Sorry, sir.
Right. Yeah. And you were mentioning that probably men do not have a major problem. And if they have, then we need to look for some additional cause like obstruction, of which, of course, in adult and elderly men, prostate is a major incriminator. But that apart, what about functional sort of obstruction, cystopathy because of long-standing diabetes, autonomic neuropathy? That could also cause some amount of retention.
I agree with you, sir. Diabetic cystopathy, or it's an autonomic dysfunction in people with diabetes, and as age advances, your chances of diabetic cystopathy go up. Your post-void residues go up. Your detrusor muscle becomes weaker. Sometimes clinically it's very difficult to diagnose. You have these patients who have nocturia with almost normal blood sugars, and clinically difficult because you will require a uroflowmetry, you will require a urodynamic study to actually look at whether there is a detrusor muscle weakness, but very, very common, especially as the age advances. And you could have other features of some kind of autonomic dysfunction, like a postural hypotension or a persistent tachycardia, or all these kinds of features in these people, both men and women with diabetes. So yes, diabetic cystopathy is a problem and one of the most common causes of recurrent infection. And many a time there's nothing one can apply except probably an indwelling catheter to many of them,
Can I get back to Dr. Shailesh Shahai on this issue? So let's say I have a gentleman of 70, 65 years, 68-year-old gentleman who has a increased post-void residue, let's say 100 milliliter of urine. He has also got an enlarged prostate size, maybe 35 grams. And I'm told by urologists that ultrasound measurement of prostate is extremely unreliable. That is what I'm told. It is your finger that feels the prostate much better than the sonologist's probe. That's what I'm told by some urologists. But in this instance, how do we know whether this residual urine is because of cystopathy or is because of the prostate?
Sir, it's a very important thing to understand what is the exact etiology leading to this voiding dysfunction. So those patients who have the ultrasound showing that prostate is, say, grade grade 1 or grade 2 enlarged, and even the DRE, distal rectal examination, confirms that, and PVR is raised. So now the first thing we do is uroflowmetry. Obviously, the uroflowmetry shows some kind of obstructed flow. So the question is to differentiate whether it's the bladder outlet obstruction due to prostate, which is leading to this widening dysfunction, or there is some bladder involvement due to the diabetes that's leading to this. So the best way to differentiate between these two entities is getting a urodynamic study, because urodynamic study is the only test which will actually give you the exact pressure measurement of the bladder, which will be saying whether it's an underactive bladder leading to widening difficulty, or it's a bladder outlet obstruction in which the pressure gets increased. So urodynamics is the answer in such patients, so that we know what is the exact pathophysiology.
So for a practicing physician, could you come up with maybe figures as to what would be the peak pressure or the void
I would say, just for ruling out the things, we should remember that on a uroflowmetry, the most important parameter is average flow. It's not the maximum flow. Many times maximum flow, maybe the average flow, it should be more than 10 milliliter per second for a patient of say around 50, 60 years of age. So 10 ml per second is the cutoff for average flow for uroflowmetry. Regarding this ultrasound PVR, as there is no it as normal and how much is significant. But in clinical practice, we take around 50 ml to be a normal thing. Less than 50 ml PVR is okay. More than 50 is little, I would say, higher side. So normally when we are treating such patient, and especially when they come for surgery and when they say that I want to get operated, so you should always be very cautious that those patients who are having underactive bladder or say diabetic cystopathy and not having significant obstruction, then my surgery is going to fail. So those patients should be subjected first for urodynamic study. Make sure that patient is having a good bladder function. So how to differentiate bladder function? Just remember the detrusor pressure should be more than 60 for a normal bladder. So if my urodynamic study is showing that a patient is having say around 20-30 centimeter of water pressure of bladder, then it means that this patient is having underactive bladder because the cutoff is 60. But if the patient is having prostate leading to bladder outlet obstruction, then his detrusor widening pressure would be much higher actually, maybe 80 or something. Then those patients with higher detrusor pressure are good candidate for surgery, because you will treat the obstruction, they will respond. But underactive bladder, maybe you have to give some kind of bethnecol or something to help in pumping the bladder, or sometime even in severe cases in which there is hardly any pumping, you have to go for CIC, like clean intermittent self-catheterization. That would be an answer rather than putting an indwelling catheter and subjecting him to multiple infection. It's better to teach them CIC and they can continue with that.
Right, great. So we remember two figures: the mean flow rate being at least 10 ml, and pressure of at least 50-60 centimeters of water.
More than 60 should be there.
Great. Right. Okay. More than 60. Right. So before we come to Dr. Pramod Gandhi, I once again remind our colleagues, our audience all across the country, that we have got three excellent members of the faculty this evening. So if you have any questions, shoot them off, put them in the chat box so that we can address them to our panelists. So Dr. Gandhi, Pramod, we are fortunate nowadays to have this new class of drugs, the SGLT2 inhibitors, which are doing wonders, which are not only reasonable in controlling glucose, but also have so many additional advantages, protecting the kidneys and protecting heart failure at least. So there is, as Dr. Coville already reacted initially, whether we are talking of genital mycotic infections, but in the context of urinary tract infections, do you think SGLT2 inhibitors lead to higher risk of urinary tract infections? And a corollary question, if someone has had a history of acute pyelonephritis in the past, would you deprive that patient from an SGLT2 inhibitor?
Yeah, thank you, sir. Basically, if we see, the use of SGLT2 inhibitor has increased since we know the benefits of SGLT2 in terms of CV benefits. So in a clinical trial setting, if you see, most of the studies had shown that the risk of urinary tract infection is not significantly different with SGLT2 inhibitors as compared to placebo group. However, in real world setting, we do see few patients who do develop urinary tract infections. As such, genital mycotic infections are almost 15 to 20% more common in patients who are using SGLT2 inhibitors, but urinary tract infections are less common. Especially in those patients, we should be very cautious while using SGLT2 inhibitor are patients who had history of recurrent UTI in the past. All diabetic patients, as Dr. Saha has clearly said, that diabetic patients has history of recurrent UTI. So we should be very cautious while using SGLT2 inhibitors in patients who had past history of recurrent urinary tract infections. We should be cautious in elderly population, both in males as well as in females, because in males we know prostatitis or cystitis, which is very common and which can lead to probably increased risk of urinary tract infections in patients who are using SGLT2 inhibitors. In elderly females, they have atrophic urethritis or atrophic vaginitis, which is associated with increased risk of urinary tract infections, and therefore we should be very cautious while using these drugs. Patients with pyelonephritis, a patient who had severe pyelonephritis in past, we should be very cautious while using SGLT2 inhibitors. I feel we have other drugs probably which can give us these cardiovascular benefits. We should use those drugs rather than using SGLT2 inhibitors in such patients, because we know if patient develops a recurrent acute pyelonephritis, it can lead to chronic pyelonephritis and ultimately chronic renal failure. So that should be avoided, and we should try to prevent the recurrent urinary tract infections in these patients. So in real world, if we select the patients judiciously, the risk of urinary tract infection with SGLT2 inhibitors is not very high. But if we don't select these patients judiciously, then probably we are also increasing the risk of pyelonephritis in these group of patients.
Right. And while I fully agree with you that the studies have not shown higher incidence of urinary tract infections with use of SGLT2 inhibitors, but they have carefully excluded the groups with some structural abnormality, some obstruction or stone or whatever. Those are not there in these studies. So whether those also having maybe a ureteral stricture or a bladder
those patients who had structural abnormality or renal stones has history of recurrent UTI or are at higher risk of developing urinary tract infection, and that's why probably those patients were excluded in these studies. So if we treat with SGLT2 inhibitors, they do have increased risk of development of urinary tract infections in these patients as well.
Right. So stay with us, Pramod, because the next question will be for you again. So it's not uncommon, as we said, for a person with diabetes to have a urinary tract infection. Many a time, most of the time, possibly it's not a severe acute pyelonephritis, but maybe relatively milder form, maybe cystitis, but maybe even a higher urinary tract infection, but not causing clinically great, not playing havoc sort of on the system. So in the context of urinary tract infection, how would you manage the glycemic control part of it?
Yeah, any patient who had who is presented with urinary tract infection with us, we should try and avoid use of SGLT2 inhibitors in these patients. And if such patient needs hospitalization, probably we will also avoid the use of SGLT2 inhibitors in this group of patients, and we will start insulin in these patients along with the oral anti-diabetic agents possibly. We should be cautious. And if this patient develops renal failure, also acute renal failure, maybe secondary to acute pyelonephritis, we will also like to avoid metformin in this group of patients during such acute illness till the time their creatinine is normalized or their eGFR is normalized, I will say.
while on the topic of urinary infection, especially affecting the kidneys, if I would ask Dr. Shailesh Shahai, where in patients of emphysematous pyelonephritis, where would you like to get involved? Where would you use your knife? Sorry, sir, please
You are
unmute
muted.
yourself. You're muted. Dr. Shai, please unmute yourself.
Yes, sir.
Yes.
So, what I am saying, this emphysematous pyelonephritis, normally a patient comes with a screening by an ultrasound. An ultrasound would be showing there is some air pockets in the kidney parenchyma or sometime in the PCS. So the first investigation we advise for a contrast CT. If the creatinine is normal, then we go for a contrast CT KUB. So in contrast CT, you have to look very carefully what is the exact location of the this gas in the kidney, whether it's in the parenchyma, whether it's in the pelvic calyceal system, whether there are some fluid content with this or it's just an air, because the management changes quite a lot with these findings. So initially when I was doing my residency, the dictum was any emphysematous pyelonephritis proven on CT needs nephrectomy because it's a kind of surgical emergency. But later on, now we have seen, and we have even literature has also quite changed a little bit. Those patients who are having no parenchyma involvement, but there is only gas in the pelvic calyceal system. So we call it emphysematous pyelitis. So in emphysematous pyelitis, there is valid role of putting a stent or sometime putting a PCM. But those patients who are having a parenchymal involvement along with fluid content with the air, so those patients are actually a surgical
I can't hear Dr. Shailesh Shahai. Maybe there's connectivity issues at his end.
patient, rather than when the patient become unstable, it becomes very high risk surgery. So that is one thing about this emphysematous pyelonephritis. Secondly, in diabetic patients, the incidences of renal abscess are also very common. But for renal abscess, mostly we are safeguarding the kidneys, and we try to put a ultrasound guided pictal first. So if there is unilocular cavity, like say 2-3 centimeter 4 centimeter cavity in the renal parenchyma showing pus collection, then pictal catheter under ultrasound guidance work very well. But if there are multiple abscesses, like say 10-15 abscesses of 1 centimeter not intercommunicating, so those candidates again go for a nephrectomy. So it's a judicious decision that we have to take, because we know that the other kidney may also be later on involved with this diabetes. So we try to safeguard the kidney as much as possible, at the same time, not at the risk of developing urosepsis. So it has to be clinical
Right.
decision based.
Right. So it's not 100% nephrectomy. There is a scope for medical treatment. Of course, we have to have a low threshold for surgery. So let's come back to the issue of SGLT2 inhibitor and genital mycotic infection, which is quite common and more so in women. So I'll ask both our physician colleagues, maybe first Dr. Rajiv Kovil and then Dr. Pramod. So what is your approach in a patient who has developed a mycotic infection on an SGLT2 inhibitor? What do? You stop the SGLT2 inhibitor? When do you stop? How do you approach?
So with the first occurrence of a genital tract infection, I would only suggest partial withdrawal, and then I will reintroduce once the patient's symptoms are better. But if it's recurrent genital tract infection, I would withdraw it, and withdraw it for forever. But I still remember a patient long time back when SGLT2s were introduced. And when I introduced the medication, her HbA1c was close to 10%. And for the first time in her life, she came below 8%. So in spite of repeated genital tract infection, she herself said that I have never achieved this kind of control. And we continued it with some amount of weekly antifungal medications. And once the sugar stabilized over a period of time, then the recurrence of these infections also came down. So if there is recurrent infection, you need to discuss, and we have to weigh the pros and cons of the SGLT2 inhibitor, discuss it with the patient, and it should be a shared decision making whether we continue. We should be having our vision absolutely right, that we are using the SGLT2 inhibitors for its value added benefits, which is other than just the glycemic benefits of it. And if that outweighs the opinion, I think genital tract infection needs to be discussed. And if the patient is ready, we would continue it. So if you have a patient with heart failure and chronic kidney disease, I would prefer that he has a genital tract infection, which I treat with an antifungal and prevent him from dying.
Right. And so, Pramod, what is your approach? And also, how do you treat this mycotic infection? Is it a local treatment or is it systemic oral antifungal that you use?
Yeah, so basically, if we know that genital mycotic infections are usually seen in the initial phases when we start this drug, and gradually most of these patients develop tolerance and they don't develop these infections. But then, if patient has mild infection, probably, especially you were talking about female patients, then in these patients we always teach these patient how to maintain the genital hygiene. Probably that education itself reduces the risk of development of recurrent genital mycotic infection significantly. And if at all they have mild infection which is persistent, probably we take the help of our gynecologist colleague and ask these patients to take either local treatment, or sometimes these patients might need systemic antifungal therapy also. Those patients who has recurrent genital mycotic infections which is intolerable, probably these are the patients whom we may not be able to continue these drugs for long term, and we might have to withdraw. It is seen almost 15 to 20% of the patients we have to withdraw the SGLT2 inhibitors because of recurrent genital mycotic infections. Otherwise, almost 70 to 80% patients do tolerate these drugs if we continue these drugs and teach them how to maintain genital hygiene. The mild infection, if it is treated with either local or systemic antifungal agents depending on their severity, and explain these patients the importance of the benefits of SGLT2 inhibitors, especially the cardiovascular and renal benefits. If you explain, these patients do tolerate these drugs very well.
Right. I would like to share my experience. I mean, we all know that the problem is more with women. Fungal infection is much more often common in women than in men. Now, I have made it a practice before starting SGLT2 inhibitor. I generally tell them about genital hygiene, that you have to wash the local part after urinating each time. Now, here comes a problem that most males, and many males, there are still in our society, there are many more males who are working outside their home during the daytime. For long hours, they are outside and they do not have private toilets. And so they say, I cannot do this. I cannot follow your prescription of washing the local part after each urination. So please don't prescribe me this drug. So this is a practical issue that I have faced. And maybe because on my own, I raised the issue. If I didn't tell them and just prescribe them, maybe they wouldn't have gotten infection. But that's an issue that I have found. So we talked quite a bit about infections, both bacterial and fungal. So we talked about the urinary system. We, of course, didn't talk about diabetic nephropathy. This is not our topic this evening. Now we try and sort of veer to another area, the genital part of the genitourinary system, and talk of sexual dysfunction. So, Dr. Gandhi, I've seen Dr. Rajiv Kovil has something else going on. He's getting a fellowship. So he wants to be excused for a few minutes. So he'll be back with us till such time, Dr. Gandhi. So how common is male sexual dysfunction? Essentially, let's say erectile dysfunction in diabetes.
Yeah, I think erectile dysfunction is one of the important macrovascular complication of the diabetes, which is quite common in patients with diabetes. And we know that erectile dysfunction in patients with diabetes is not only vascular, but it's even neurogenic as well. So there are two components of erectile dysfunction, neurogenic as well as the vascular component. it's a macrovascular complication. It is seen very commonly in males.
Micro or macrovascular? Sorry, did you
It's
say
a
microvascular?
macrovascular complication.
Macro, that's a vascular, but the neuro part is a microvascular.
Neuro is microvascular. So it's a mixed picture which we see,
Yeah.
and in most of the patient, it is not. It is extremely difficult to segregate whether it is neurogenic or whether it is vascular reason for the erectile dysfunction. So most of the times it's combined feature, and in Indian setting we have seen that unless you ask the leading question to the patients, these patients don't come out with the symptoms. So it is extremely difficult to find out the prevalence of erectile dysfunction, but it is quite common in our population. Almost 25 to 30% of the patients do develop erectile dysfunction. Unless these patients are in our society, Indian society, unless you ask leading questions, they won't come out with the this problem in our day-to-day OPD.
Right. So if someone complains of erectile dysfunction, what is the evaluation that you would do?
Any
Our
patient who,
physician colleagues would do.
yeah, any patient who has history of erectile dysfunction, first thing is basically we need to evaluate we need to take detailed history, clinical examination, including the local genital examination, which includes a lot of surgical problems. Dr. Sahai will be able to answer all those things, but then a lot of surgical local problems which can be addressed easily. We also need to take the detailed history in terms of the drug history. There are many drugs which can cause erectile dysfunction, including beta blocker, ACE inhibitors, ARBs, sometimes even thiazide group of drugs.
Yeah.
These are the drugs which we should see, and if we are able to withdraw these drugs, probably in most of the patients, these patients do improve after withdrawing these drugs. And then after that, we need to, there is a battery of evaluation including serum testosterone, FSH, LH, which will tell us whether the patient has hypergonadotrophic hypogonadism or hypogonadotrophic hypogonadism. That has to be evaluated. Hypogonadotrophic hypogonadism is quite common in patients with type 2 diabetes as well. So we need to evaluate the reason for hypogonadism also in these patients.
Right. So my approach, at least in these instances of erectile dysfunction, is to ask at least simple question whether the desire, the libido is also there. If the libido is there, I generally do not ask for hormone tests. Because if testosterone is low, then usually the libido is low, not just selectively only the erectile function. I mean, that's my personal way of dealing with it. Also partly to relieve our patients of too many investigations. So that's just the way that I usually follow. Yeah, so exactly. But what about, let's say, vascular flow? You said significant vascular cause for erectile dysfunction. Do we need to go into penile Doppler study and all that? And in the olden days, the stamp test or something, those used to be done. So are they relevant? Are they important?
I think penile Doppler study is very important. That will tell us the presence of vascular disease or in these patients, and that helps us to know whether it is vascular cause which is predominant or whether it is neurogenic cause which is predominant. Then one more history which I would like to ask you, as you said rightly, is early morning erection, which tells us whether it is psychogenic erectile dysfunction or organic erectile dysfunction. That also is very important. Those patients who do get early morning erections, they do have, it's more of a psychogenic component of erectile dysfunction.
Right. So Dr. Kovil seems to be back. So
I couldn't hear your question, sir.
No. So the question is coming. So
okay.
Where's your trophy? Where's your trophy? Your fellowship or something?
I'll send it. So sorry. Yeah.
Okay. Okay, good. So we are on the issue of erectile dysfunction. So if you find a your patient with diabetes with erectile dysfunction, do you treat it yourself, and then how do you treat it? And then where would you like Dr. Shailesh Sahai's help?
So, sir, it all depends upon the patient's what do you call his anxiety towards it. Because if you do a question on a survey with most of our people long standing in the middle age, you would have 50% of them complaining of erectile dysfunction. So first I would like to evaluate it, whether there are any causes. First get his sugar under control, look for any simple hormonal issues like thyroid, or whether there's a liver dysfunction. Get his testosterone done, get his PSA done. If he has a LOH, treat that. If he doesn't have it, finally, obviously with a lot of counseling, put him on a PDE5 and see whether it helps. My referral to a urologist is when the drugs don't work, and that's the time I would refer to a urologist, because otherwise the load would be very very high, and only when I need any kind of assisted devices or any kind of injectable therapy for to be given, I would refer to the urologist, because otherwise 1 out of 3, 1 out of 2 patients would have some form of erectile dysfunction.
Right. So what is the prevalence of uh, failure on PDE5 inhibitor?
So PDE5 inhibitors, the failure rate, I would say, I would kind of put it on that the IEF questionnaire and see how much of satisfaction is the patient getting. What do we mean as failure? If the patient is able to have a penetrative sex for with the PDE5, I am happy continuing it. If the patient's quality of life before and after doesn't change, obviously it's a failure. Failure is not very high, but at least 25 to 30%. And there would be other factors which could be lifestyle related, obesity being the most important factor, tobacco, alcohol being the most important factor. So one has to look at all those factors being completely out of the picture before we speak about failure. So just good lifestyle and removal of these habits and PDE5 would help in the eventual improvement of quality of life of of the patient. So a lot of factors need to be considered there.
And the failure rates are recognized to be higher in those with diabetes than without diabetes. So Dr. Sahai, so what as a surgeon can you offer to these patients with erectile dysfunction, and how would you evaluate them?
See, as Dr. Coville said that 1 out of 3 patients actually, when they come to us, initial investigation, mostly they are already done. Like hormonal study is done and that is normal. I agree with your point of view. If the patient is having normal libido, there's no need to go for testosterone. In my clinical practice, hardly 1 out of 20 patients I find that they have a low testosterone for ED. So normally ED testosterone is most of the time they comes as a normal. So what is more important is, see, the patient is having diabetes and erectile dysfunction, but all patients of erectile dysfunction are not having a problem due to diabetes. 75% of the ED patient, they have psychogenic component. So even if the patient is diabetic, psychogenic problem, and that is leading to ED. So most important is to give a office sildenafil test. As you said that you give medicine, sildenafil, tadalafil, these are the different PDE5 that we use. So initially, we do not go for a penile Doppler test or invasive test on the first visit. We give the patient advice that to take this medicine 1 hour before intercourse, take it 2 times or 3 times a week, SOS, and then you come back maybe after 2-3 weeks and tell me how much it benefited you. Those patients who have benefited, actually they are having mostly psychogenic erectile dysfunction and they do well. So if that drug has done well, we do not go for invasive test. If the medicine has not helped the patient, then also rule out that there is no severe balanoposthitis which is leading to this. Many times I have seen patients, they have painful condition. The penis, the penile skin is quite cracked. There are multiple cracks leading to infection. So in those patients, they are not having a good erection due to pain, because when they are having intercourse, they have a painful thing and they don't want to go for it. So if those things are ruled out, then we go for pipe test, which is penile, pipevarin induced penile erection test. So in those patients, we see the flow of the blood velocity we see on the both the cavernosal artery. If the velocity is more than 25 centimeter per second, then they are counted as normal flow. So if there is normal flow in those patients, then they are not a surgical candidate. In normal flow patient, you need to increase the dose of the PDE5, or you try other medicine and then see the effect. But if the flow is less than 25, like 10, 15, or there is rapid venous runoff, it means there is venous incompetency. There is a good flow, but the veins are leaky and they just run off. So in those patients, you have to go for surgical means. So in my practice, the surgery for erectile dysfunction is offered only to those patients who fail on all kind of medicine. Because see, you are placing an implant, means you are abolishing all the natural erection processes. Once the implant has been placed, the natural erection is totally lost. So we need to explain the patient very in detail that putting an implant, maybe it's a erect and you feel good, but it's not normal and it's not natural. So natural erection is lost forever. So if those patients who are not having any erection despite all these medicines or some injectable therapy or vacuum erection devices, those have failed, then you take the patient for this implant placement. Now coming to implant, a diabetic patient who know that HbA1c is say 8.5 or 9, and you are placing an implant, then always choose the implant very cautiously. There are two different kind of implant in the market. One is the Indian one, which is named as shaft prosthesis. So that is devised by one of the Indian colleague, and that is very cheap, and I would say cheaper in the rate, and it's easily available. That cost around not more than say 10,000 or 15,000. It's very affordable. But if you go for the other implant, which is the American, we call it American medical system, they have device like 2-piece or 3-piece inflatable devices. So inflatable devices means you just use a button and you inflate it at the need, and as well as you can deflate it also. So that's a little complex system. The cost is also just for the device, the cost is around 9 to 10 lakh rupees. So if you are placing an implant, which is say 9-10 lakh rupees, and the surgical cost and everything, if you add up, it becomes 12-13 lakh rupees. And those patients, if they have uncontrolled diabetes, there are very, very high chances of implant infection. And if you get the implant infected, there is no other option than to explant it and throw in the dustbin. So if you say like 10 lakh rupees and it's risky and it may be lost, then we always counsel such patients. You see, you have a high risk of infection. So maybe a semi-rigid device may be suitable for you. That is cost effective also. And as there is no fluid inside, it's a solid silicone prosthesis. So chances of infection are very, very less. So patient do well. Psychologically also, if you counsel them well, although it's not a natural erection that you will have, but your sexual life would be ongoing and it's better than not to have anything. So we counsel and choose the patient selectively. So 3-piece implant or inflatable implant is only for those patients who have well-controlled sugar.
Right. So it's a lot of counseling that needs to go into it, and I think we need to involve the couple, the wife also in these discussions, because sometimes the man may just say nothing is wrong, but the wife would point out, no, he's not able to perform. So we need to have a couple discussing all this. So if Dr. Shailesh Sahai can still be accessed, I cannot hear you anymore. There's a question for you, because now you have a few questions in the chat box. This is Dr. Saurabh Goyal, who wants to know the management of diabetic cystopathy. You did mention, maybe if Dr. Sahai is not there, maybe Dr. Kovil, would you like to talk about it? We discussed a little bit about diabetic
I think
cystopathy.
the diabetic cystopathy is like is a gun which cannot fire, and there's not much of treatment. If you have detrusor muscle atrophy and detrusor muscle weakness, nothing much can be done. If the UDS shows that there is obstruction, and that seems to be the issue. You may get some benefit. Otherwise, some kind of toilet training to make sure the post-void residue is lower with whatever detrusor muscle activity is there, so that regular voiding without actually having the kind of sensation, and some toilet training may help in preventing urinary tract infection. Otherwise, if the post void keeps on continuing and you go into retention, and sometimes retention with overflow incontinence, you may require an indwelling catheter continuously. That's
Right, but drugs like methanicol, how effective are they?
so
Now,
they
Yeah.
do use bethanicol at lower dosage, 25 milligram 3 times, and some amount of benefit, but I think it's very small benefit for patients for a shorter period of time. So if your detrusor is really weak, I don't think much benefit that you get. Yes, your symptomatic benefit in terms of an over activity and probably the frequency of your polyuria may go down, but overall there's no benefit per se.
Right, and as Dr. Sahai has already mentioned, rather than straight away going for an indwelling catheter, possibly it's better to try at least initially intermittent self-catheterization. And if the patient does not agree to this or doesn't have a close relation who can do it on a regular basis, then maybe the final answer has to be something like a long-term indwelling catheter, but with this attendant significantly increased risk of urinary infection. So I'll ask Dr. Gandhi, because we have got a question, Dr. Gupta, I don't know his first name. Any role of SGLT2 inhibitors in pre-diabetes? Of course, this is not about pre-diabetes, but because we did mention SGLT2 inhibitors a few times. So, Dr. Gandhi, will you quickly take this question?
Yeah, for pre-diabetes, SGLT2 inhibitors has not been studied, and it has not been recommended till date. So as of now, we are not using SGLT2 inhibitors for pre-diabetic patients. No.
Right, and maybe you stay on with us. This Dr. Kaushik, who states SGLT2 inhibitors demonstrate some beneficial effects in sperm motility and count in preclinical study. I mean, I'm not aware of it. And then what is your opinion on using it in erectile dysfunction in type 2 diabetes?
I think first thing is I am not aware about the improvement in the sperm motility with SGLT2 inhibitors. I think there are no documented studies, probably some preclinical studies, and anecdotal
maybe,
papers
yeah.
does not have any significance. The second part, improvement in terms of erectile dysfunction. Again, these drugs do not help in improving the erectile dysfunction. On the contrary, I will say other way around, that those patients who develop genital mycotic infection secondary to SGLT2 inhibitors, as Dr. Sahai has clearly said, that these patients have increased risk of development of erectile dysfunction, maybe because of local infection. So we need to treat that part also.
Right. And we still stay with you, Pramod, because you talked about testosterone in males in type 2 diabetes. We do know there is element of hypogonadism. So what is the role of testosterone in type 2 diabetes?
In patients with type 2 diabetes who has erectile dysfunction, if the cause for erectile dysfunction is hypogonadism, which is documented by doing repeated serum testosterone, which is less than maybe 3, or some people say less than 2.7, which is persistently low, documented on 2 to 3 different occasions, these are the patients who are benefited with testosterone replacement therapy in these patients. And usually these patients needs testosterone testosterone or sustanon 100 milligram once in a month or once in 3 weeks. That's the usual replacement dose. This is injectable. There are various preparations of testosterone replacement therapy which are available to us. Either it is intramuscular short acting oral testosterone, intramuscular longer acting testosterone, transdermal patches, testosterone gels. All these preparations are available to us, which can be used for the replacement therapy and to improve the erectile dysfunction in these patients only in those patients who has documented hypogonadism. Otherwise, those patients who do not have any evidence of documented hypogonadism, testosterone replacement therapy is not going to help in these patients.
But beyond sexual function, what about the metabolic health? Does it help? What are your views?
Yeah, these are the drugs which do help in terms of improving the metabolic health. These are the drugs which improves the muscle mass. These are the drugs which reduces the lean body mass. That means they reduces the fat mass and increases the muscle mass. These are the patients in whom lipid profile improves. Lipid profile is one thing where we see that their LDL reduces if testosterone replacement therapy is replaced adequately. Excess of testosterone will also alter the lipid profile. Hypogonadism or low testosterone will also alter the lipid profile. So that has to be kept in mind. Then these patients do improve the bone density in terms of we can prevent the significant osteoporosis. Overall sense of well-being is there, energetic feeling is there. So a lot of pleiotropic benefits and other metabolic benefits are also seen in these patients with testosterone replacement therapy.
Right. But of course, as you said, we first need to document that there is low testosterone. Otherwise, it won't produce these effects. So we talk a lot about male sexual dysfunction in diabetes, erectile dysfunction. So, Dr. Rajiv Kovil, what about female sexual dysfunction? Is that an area that deserves
I think that, sir, it's a prevalent problem, but inadequately addressed, and that gender bias continues because a lot of women don't complain. The most common female sexual dysfunction is again loss of desire, also lack of arousal when there is desire, lack of orgasm, and also painful penetrative sex. So these are all issues which somehow because of we being male, a lot of women still have that hurdle in speaking to their male counterparts or male doctors about it, and it remains to be a problem. However, gynecologists are the ones who get to hear these things from patients, and sometimes when they are referred to us, we have been given the background. Not much of therapy except some estrogen analogs, some estrogen local creams, but mainly counseling, and that's some androgen therapy, some data on a little benefit, but nothing much per se there, even to help them with, unless it's a painful penetrative sex is where the problem is, which can be helped. But many a time genital hygiene, prevention of genital tract infections do improve their quality of sexual function. These are simple things that we could advise, but not really therapies which can really make a 360-degree change in their quality of life.
Could PDE5 inhibitors have any role in female sexual dysfunction?
Yes, so there are data of PDE5 also in female sexual dysfunction. Unfortunately, I haven't tried them on any of them to have a personal experience. There is data supporting that at a much lower dose, but I haven't tried them, so I may not be at the liberty to actually answer the clinical outcome of these patients who have been on them.
Right. Now we are almost at the end of our 1 hour allotted time. So there's another, which is a relatively rare condition. I don't know, as a surgeon, Dr. Shailesh Sahai may be meeting more often, Fournier's gangrene. So how often do you see that as a problem? And these days it is suggested that use of SGLT2 inhibitors, apart from increasing genital mycotic infections, may also increase the risk of Fournier's gangrene, which is a very serious condition. Yes.
So I have seen only two in my life. One was 25 years back in a government hospital, and one around 7-8 years back in a private hospital. So I've just seen two Fournier's gangrene, and I believe the higher chances of Fournier's gangrene in the Caucasian world is because of poor personal hygiene. Indians are better at hygiene, and probably the usage of water is better than toilet paper. And we do take a bath every day. Some take a bath twice or thrice in a day. SGLT2 induce Fournier's gangrene, nor have I seen, nor have I heard from any of my colleagues in India. So that is blown out of proportion, I would say, to have a Fournier's gangrene. But Fournier's is kind of a necrotizing fasciitis, and you need a patient with poor metabolic control and multiple other complications, bedridden, and all those kinds of things to come together for the bomb to explode. So I think it is a sad situation of a poorly metabolically controlled patient, a long-standing elderly diabetic patient who develops a Fournier's gangrene. Over to you, sir.
Yeah, Dr. Shahai, your comments on
I would just
Fournier's.
rapidly give one of my experience. I have seen almost say 25 to 30 Fournier's gangrene in my last almost 20 years career, and 90% of them were diabetic. So this is a truth that if the patient is having Fournier's gangrene, we look for diabetes, we search for diabetes because they are diabetic. Secondly, all those patients need surgical treatment, no doubt about that. And regarding SGLT2 inhibitor, I have seen recently for last 4-5 years when this has become very common actually. So patients coming with a UTI, there is no antecedent predisposing factors. We do uroflowmetry, we do ultrasound, everything is normal, but you get only 3+ sugar in urine routine microscopy, and patient is having recurrent UTI and he is taking SGLT2, and he has ballonoprostatitis or clinical examination. So when I asked my endocrinologist colleagues, so can you please change the medicine and see if something else works? To my surprise, almost 80-90% of the patient improved after discontinuing with SGLT. They did not even need surgery for circumcision. So that was something that I would like to put forward. That this SGLT2 inhibitor, when it's causing ballonoprostatitis, and if you stop it, then everything gets reversed and patient has very good outcome. So this is something that need to be viewed. Ki maybe literature does not support this infection. As a urologist, I see daily these things happens.
Right. So as almost as a counterpoint, we have Dr. Kaushik again putting a question, and we will have Dr. Pramod Gandhi answering. So when glucose control is mildly impaired and we initiate SGLT2 inhibitor, shall we actually reduce the risk of UTI? So we had now Dr. Shaileshai telling us that if you stop SGLT2 inhibitor, urinary tract infection may become less. Now Dr. Kaushik wants to know whether by advising SGLT2 inhibitor, you can reduce the risk of UTI.
By a patient who already has recurrent UTI, even after good glycemic control, we should try and avoid SGLT2 inhibitors. If patient has history of recurrent UTI or any other risk factor for that matter, which we have discussed, that elderly patients and then those with local abnormalities or those with renal stones, in these patients definitely we should try and avoid these drugs. But then a patient who has mild UTI for the first time, one episode which was treated spontaneous, and after that if we start SGLT2 inhibitors, reintroduce SGLT2 inhibitor for good glycemic control, probably these patients may not develop UTIs if it is not SGLT2 induced. And if at all they develop recurrent UTI, then probably we are justified in stopping the drug.
Right. So by and large, the physician and the surgeon are all are both on the same boat. So thank you. I think we had a very educative session this evening, starting with infections, the urinary tract infections, genital mycotic infections, bladder dysfunction, and then eventually erectile dysfunction, especially in males. And then also recognizing that sexual dysfunction does happen more often in women also, though at this point of time, our treatment is not as well developed as it is for males, but that's an area to work on. So I would like to thank all of those of you who joined this evening, and I'm told I had some figures, almost more than 900 of physicians have joined from across the country, and it's only because of you people, Dr. Pramod Gandhi, Dr. Rajiv Kovil, and Dr. Shailesh Sahai for sharing your experience and your knowledge. Thank you very much. It has been a wonderful evening for all of us. And I also thank from the bottom of my heart the INTAS team led by Mr. Amit Arora, and there are so many other members who work very hard to bring this program month after month. So over to the organizers.
Thank you, Professor Shubhankar sir. I think on behalf of INTAS, I would first of like to thank you because you give us such topics which are really interesting for the physicians across the country, and they would like to come and join and listen to the experts who join in this program. And as you rightly said in the beginning of the program, we have been running this program successfully for more than 2 years now. I think June 2020 we started with Practice Pulse in endocrinology, and now we have converted this program into a talk show. And as you rightly said, that it is purely an educative program, and that is what we intend to do in this as a division. We definitely are in diabetes management with most of the recent molecules like sitagliptin and dapagliflozin and all that, but we don't have any other products, for treating infections or sexual dysfunction or erectile dysfunction, all these things. So we like to bring these, practice pearls for the pure education for the physicians, and that is what our intention is. And probably the kind of audience that we get every time, again, we have crossed the figure of 1000 now, because that figure that I sent you was around 830. So now we had more than 1000 delegates who joined in from across the country. I must thank all of them for joining in today and listening to our experts. And I would like to thank the faculty, Dr. Pramod Gandhi, who has come on this platform for the first time. Thank you very much, sir, for joining in. We have Dr. Shailesh Sahai, who joined in, on the request of our colleague who handles the urology business. And we have, of course, Dr. Rajiv Kovil from Mumbai, who joined in today and gave his expert comments in the program today. I must thank our technical team and field staff for vigorously doing follow-up with the doctors, and they joined in today in this program. So thank you very much once again, and stay tuned for our next episode, which is going to be next month. For that, we'll give you another exciting topic with the help of Dr. Shubhankar Chaudhary. So thank you very much, and good night to all of you from here at INTAS. Good night and thank you.
Thank you, sir.